In this week's Cardiology News, we have the interaction of renal function and outcomes in atrial fibrillation, flu vaccine and MI, and a look at ARB efficacy using ambulatory blood pressure monitoring. So to begin with, we have a sub-study analysis from the AMADEUS trial that looked at a long-acting low molecular weight heparin versus warfarin in atrial fibrillation, and the interaction of impaired renal function and outcomes, both stroke and bleeding. And not that surprisingly, patients with a creatinine clearance of less than 60 cc's per minute had about a doubling of bleeding risk and stroke risk. Now, when adjusting for some of the baseline characteristics, that outcome relationship softened, but bleeding risk was definitely still present, and there wasn't an interaction by the type of anticoagulant. And so it's a reminder, I think, to all of us that renal function is a big factor that we need to look carefully at dosing and recall that these are high-risk patients. Next up, we have an interesting case control study looking at the influence of influenza, both the disease on creating MI and vaccine against protecting MI. This was a study of about 550 patients where they looked at cases with acute MI and controls as outpatients who didn't, and found, interestingly, that prior to MI, a good percentage, about 12%, had influenza in the prior month or so, although that difference softened with multivariate adjustment in this moderate size. But what didn't was that patients who had been vaccinated against influenza had about half the risk of developing MI. And this is consistent with some other data that have been looked at in prior small studies, randomized trials of influenza vaccine. And so a growing body of evidence, really, suggesting that flu vaccine may protect against MI. And a top pick this week is a very large study that did an overview of all the trials that looked at ambulatory blood pressure monitoring and angiotensin receptor blockade, and looked at differences of drugs and dose. And so they explored what is the dose response as you increase the dose from 25%, 50% up to the maximum dose. And they report a relatively shallow dose response where, on average, blood pressure systolic decrease at the 25% max dose was a drop of 10 points, then 12 for the 50%, and 13 millimeters of mercury for the max dose across all the different ARBs. And this comprised over 15,000 patients in 62 different studies. They interestingly also looked at different agents and found that losartan seemed to have significantly lower blood pressure reduction than all the other ARBs trying to match per dose. And so while last week we talked about the importance of having a full dose proven for ACE inhibitors and statins, here for ARBs it may be a little less clear as to whether you need to push to the maximum dose in order to get the most benefit. So I think intriguing looks at the interplay of dose and efficacy. So for this week's Cardiology News on CardioSource, I'm Chris Cannon.